I just wanted to welcome everybody to tonight's edition of the Florida Foot and Ankle Fellowship Society webinar series of excellence, the Roundtable of Excellence. Just a couple things about the Florida Foot and Ankle Fellowship Society. This was an initiative that was co-founded through the Florida Pediatric Medical Society and FPMA. The Florida Foot and Ankle Fellowship Society, with the support of the FPMA, our goal is to lead the way in promotion, coordination, and advancement of fellowship training, both locally, regionally, and nationally. As stated, we're part of the Florida Pediatric Medical Society, which is a non-for-profit arm of the FPMA, and we're very grateful for that relationship. Just a word about our mission. We want to encourage the growth of fellowship training opportunities in the state of Florida. We want to plant the seeds for tomorrow's future thought leaders, the innovators, the educators, and researchers, and promote the advancement of surgical training and education through fellowship. The benefit of the Roundtable of Excellence, we focus on education. So that's the creation of this new academic series. We're on our second year of this. What it's doing is it's helping satisfy educational goals with updated and relevant content. And as everybody kind of stated, we're all really excited about tonight's because this is something that I think at some point we get asked about in our practices, even if we don't have pediatric experience. So those of us that do know that this is a challenging condition. It's a challenging conversation to have with parents when you should have a surgery and when you shouldn't. Monthly exposure to unique fellowship training opportunities, not only in Florida, but we have, as tonight, brought in fellowships from across the country. We're also about promotion. We want to promote the benefits and impact of fellowship training on our profession locally, nationally, and within the industry. And finally, the last part of what we do is sponsorship. So that allows for industry to partner with us and support fellowship training initiatives, sending our fellows on missions or foreign training opportunities, or just kind of getting together as fellows and kind of understanding the benefits of the networking that occurs with the gathering of all the fellowships and all the fellows together for these types of activities. Tonight's talk is presented by Dr. Mark Solomon and Dr. Joslin Seidel. It's a Pediatric Foot and Ankle Fellowship out of New Jersey in Pediatrics. And I believe tonight's topic is focused primarily on juvenile Hallux valgus. So without further ado, we'd like to welcome one more thing I do want to say is thank you to all the sponsors. This whole series would not be possible without industry's support in this. And we're really excited about where we've come so far, but also where we're headed to with this initiative. And at one point, we hope that this becomes more of a national-based initiative. So without further ado, I'd like to hand it over to Dr. Solomon and Dr. Seidel.
Hi, good evening. My name is Dr. Mark Solomon. I'm the director of the Pediatric Foot and Ankle Fellowship in Cedar, Knolls, New Jersey. We've been, the common goal of this program sounds wonderful. It reminds me of something one of my mentors, Dr. Rieger, who's our senior partner, constantly says, which is that when the tide comes in, all the boats raise in the harbor. So, trying to raise education amongst all the fellowships is, a fantastic idea. And, I'm really glad that you guys started this and are constantly promoting it. And, we're happy to be a part of this. As far as fellowship goes, we started our fellowship about 5 years ago. I finished my residency at Morristown. I was the first resident there and was very fortunate to be taken under the wing of the pediatric orthopedics group at the time. And then over the years, we have, come to our own common goal, which is try to help the kid, succeed. So it's always been something that, we put first and foremost. There's no egos. We all work together on a daily basis. They come back and ask, a question about a foot or ankle, or just send us the patient. If there's a deformity, we work together as a team, whether there's a femoral deformity, a hip deformity, tibial deformity, we plan out together and work together, which is, again, for best interest of the child. The initiative started 5 years ago because I was also a CPME site reviewer for American Board of Foot and Ankle Surgery. And after visiting many residency programs, I came to realize that what we were doing really didn't happen as in residency. And we believe that my partners and I all believe that we wanted to help educate and kind of teach what we learned to help kids everywhere and kind of spread our seed across the country. So we've been very fortunate that all of our fellows are extremely successful. The last two, especially Dr. Goldstein, went out to California, was the first podiatrist on staff at Valley Children's Hospital in Fresno. And Dr. Ferraro, our last fellow, is at LA Children's Hospital, again, the first podiatrist on staff there, from what I know. So that's really what we wanted to do. We wanted to be able to send out people from our profession to help and join pediatric orthopedics in other parts of the country, much like Dr. Lamb has done from the very beginning. So we work integrally with the fellow, and fellow is taught by every single one of us, has an opportunity to make the fellowship what they like, so they can rotate with any one of our partners. They're always welcome into the OR or into the exam room with them. We're the only Ponseti center in New Jersey, so there's a good amount of Ponseti. Our senior partner, Dr. Rieger, trained with Ignacio Ponseti. So fellow has a good amount of exposure to that. So at this point, I think I talked enough about ourselves, and it's probably better to hear from the fellow. So Joslin, please.
I would probably mirror exactly what he said. Dr. Solomon really does let me make this my experience, whatever I want to do. And anybody that kind of came in, he would help do the same. I've taken a lot of opportunity to do different trainings kind of all over the country, usually sponsored by different distributors. And then some other ones, like I just went down to Dallas and did controversies in pediatric limb reconstruction, which was incredible. I was the only DPM down there. Everybody else was DOs or MDs. So I learned a lot in that. And I've done a lot of trainings like that kind of all over the country. That's something that I've chose to do. I just really learned best by hands-on and doing. So had a lot of opportunities there and have seen all sorts of things from just simple like sports medicine type stuff with pediatrics to trauma with like open fractures, as well as big deformity reconstruction, which we do with Dr. Solomon's orthopedic partners and kind of usually go in to cases together, and have done some different clubfoot cases and some other cases, which we would be happy to share again at a different time. This time I was asked to talk about Hallux valgus, but we can also do another lecture and share some of our other different type of cases that we do. So, like I said, I was asked to talk about pediatric Hallux valgus. I'm Joslin Seidel, the current fellow at the Pediatric Foot and Ankle Fellowship in Cedar, Knolls, New Jersey. So I have no disclosures, no off-label use during this lecture. Although the true incidence is unknown and is more likely in females versus males. This is more likely bilateral versus unilateral. Coughlin reported that maternal transmission of 72% in patients. Despite that statistic, we commonly ask our patients when they come in, and from our patient population, we haven't seen that high of a statistic. And unlike our adult patients, when pediatric patients come in, the pain is usually not their primary issue. Most oftenly, our patients are athletes and they have trouble with shoe gear and issues with shoe gear. Juvenile Hallux valgus or pediatric Hallux valgus starts developing at age 8. Our patients don't often develop symptoms until around age 10. Despite development of the deformity at this age, a patient may choose to seek medical treatment later in life. Depending on the age of presentation, the physis of the first metatarsal may be open or closed, which is something to take into consideration when determining your type of deformity correction. We all know that this is a triplanar deformity, and a study by Mortar and colleagues found metatarsal pronation to be associated with Hallux valgus, making a preoperative AP image very useful. And the underlying mechanism was generally metatarsal cuneiform instability. And so the question most people have is, when do we fix this deformity? So we'll start by talking about some literature, the angles and dangles. Pes planus identified in 17% of patients, which is similar to the incidence in the normal population. The presence of pes planus in this study was not thought to have an effect on the occurrence or the recurrence of the deformity. Metatarsus adductus was noted in 22% of the subjects, which is a rate much higher than that of the normal population, and the presence of metatarsus adductus did not affect the preoperative hallux valgus angle or the surgical correction. It is commonly believed that footwear plays a major role in the development of the deformity. However, in this study, constrictive footwear was only noted in 24% of the patients. Even though the incidence of a long first metatarsal was similar to the normal population, there was a correlation with a long first metatarsal and an increased distal metatarsal articular set angle. So Coughlin believed an increase in that distal metatarsal articular set angle may be the defining characteristic of juvenile hallux valgus, and the success of surgical correction is intimately associated with the magnitude of that increase or elevation in the distal metatarsal articular set angle. In this study, early onset, which they described as greater than 10 years of, or less than 10 years of age, was associated with a greater deformity and a larger distal metatarsal articular set angle. This deformity can originate because of lateral deviation of the articular surface of the metatarsal head without subluxation of the first metatarsal phalangeal joint. So with subluxation of the first metatarsal phalangeal joint, the average distal metatarsal articular set angle was 7.9 degrees. However, with a congruent joint, the average distal metatarsal articular set angle was 15.3 degrees. So quite a bit of difference there. This is a level 3 retrospective comparative series of 163 patients with juvenile hallux valgus, which they defined as an HAV angle greater than 20. 12 radiographic variables were analyzed, and there was no statistical significant difference in hindfoot alignment, and symptomatic and asymptomatic subsets showed no statistical radiographic difference. So they concluded radiographic profiles in patients with this deformity were inconsistent with regards to the features of flat foot, and the degree of deformity was unrelated to the presence of symptoms. This is a cohort by Voss and colleagues to evaluate the relevance of the metatarsal cuneiform joint. They compared 46 feet to an age-matched control group of 36 normal feet. They evaluated 8 angles and associations. The COA, which was define the intrinsic obliquity of your medial cuneiform articular angle, was not significantly different, suggesting that the cuneiform morphology is not involved in juvenile hallux valgus. However, the met cuneiform joint was identified as a contributor to the increased intermetatarsal angle and thus would contribute to your hallux valgus deformity. So the met cuneiform joint should be taken into account when we are surgically correcting this deformity. This is a study by Kaiser and colleagues to determine what angles are actually important. This was a level 3 comparative study of 93 feet with hallux valgus versus 50 normal feet. They analyzed 9 different radiographic angles, and the study found that juvenile hallux valgus was highly correlated with the morphology of the first met cuneiform, or the first metatarsal and met cuneiform. So they determined that the distal metatarsal articular set angle was the main driving force. Metatarsal cuneiform deformity was second, with intermetatarsal angle and varus position directly affecting the hallux valgus angle, and the relative length of the first metatarsal correlated with the severity of the deformity. So from those studies, take homes here is understanding that this is a complex triplanar deformity with multiple factors to consider when planning deformity correction, including proximal deformities such as your metatarsal cuneiform deformity, the angulation, and the possibility of varus position, as well as distal deformity, which is commonly defined by the distal metatarsal articular set angle, and you want to assess metatarsal length when determining surgical planning to watch for either lengthening or shortening, depending on your metatarsal parabola with your surgical procedure. So moving on to physical injury. There are several risk factors that have been identified. Here's a long list of intrinsic factors associated with physical injury. Clark and colleagues had a series of 73 patients, and they reported 69% of juvenile patients had generalized ligament laxity on physical exam, something that you can do in clinic a couple different exam criterias is the Wynn and Davies criteria and the Baton score, which are commonly used to detect ligament laxity. There's some pictures here showing those scoring systems. So that's an important thing to, important and easy thing that you can use to assess your patients for ligament laxity, because that will change your surgical procedure. Another noteworthy thing on this list here is an oblique met cuneiform joint or atavistic medial cuneiform is also something that you want to identify in your patient, and that will also change your can change your decision for surgical planning. Here's some instances of traumatic risk factors for physical injury. Here there are 3 independent reports. Fabic and colleagues described a case of traumatic rupture of the medial collateral ligament in a great toe of a soccer player, which progressed to hallux valgus deformity. Another case report by Johal and colleagues described an acute post-traumatic hallux valgus following a tibial shaft fracture with entrapment and injury to the medial plantar nerve. And Boha and colleagues reported 7 cases in which Liz Frank joint injury led to first met cuneiform joint instability and thus later hallux valgus. So this could be due to a previous trauma. Anderson and colleagues analyzed the rate of pedal growth and determined that full female foot growth is usually achieved at 14 years of age. So when females are roughly around age 12, an average of less than 1 centimeter of total longitudinal foot growth remains, and less than 50% of this longitudinal foot growth occurs in the proximal first metatarsal epiphysis. So a relatively small amount of growth occurring in that first ray after the age of 12 when we are talking about females. However, in adolescent males, completion of growth tends to occur around age 16. So by 12, males still have 3 centimeters of growth remaining in the foot. Again, estimated 50% of the remaining growth occurs in that first metatarsal epiphysis, equating to approximately 1.5 centimeters of remaining metatarsal growth. So males have quite a bit more growth remaining at the same age of 12 as compared to females. So other factors that affect the physis, increased, like described before, increase of obliquity with an atavistic cuneiform leads to asymmetric growth of the first metatarsal. It's thought that the mechanical loading influences the rate of longitudinal growth, referring to the Hutter-Volkmann law, which proposes that growth is retarded by increased mechanical compression and accelerated by reducing loads in comparison to the compressed side or in comparison with normal values. So a high met cuneiform angle causes compression at the medial first met base, leading to the lateral aspect of the base to grow faster than the medial aspect. Longitudinal growth ceases at skeletal maturity. With fusion of the physes, there are many factors that affect this physical closure, and it happens at different times in different bones, and as well as different times in different ages, like we just saw in the previous study. Things that affect it: gender, hereditary factors, and hormone levels. Physical closure is normal in everybody, and it is gradual osseous replacement of the growth plate closure, and this is driven by this is induced by estrogen in both males and in females. So moving on to surgical treatment, we'll talk about guided growth, MIS, and first tarsometatarsal joint fusions, as those are the 3 primary surgical options. So decision-making, here are some key elements. Clearly, there are several things to take into consideration when determining your type of surgical correction on these patients. Age is important because it'll dictate your procedural choice. Historically, I think people used to think that it was necessary to wait till your physes close before even considering any type of surgical intervention. However, nowadays, there are definitely several ways that we can help the patient without, or correct the deformity without the growth plate being closed. For example, if the growth plate of the first metatarsal base is still open and the patient does not have like diffuse ligament laxity, we will do a minimal incision surgical technique and place the screws further distal than the physis to not affect the physis. And then, like all surgery, we need to consider the potential for future deformity and or disability. And of course, managing patient and parent expectations is extremely important, as with anything. So here, this study brought up, this is a very interesting fact. They reported that after preoperative discussion of risks and complications, the recall rate of individual risks is only 10% or less. So you want to make sure that patients fully understand that there is going to be some residual stiffness, pain, or deformity may occur after you correct it. Having that discussion with parents and patients so that they know all of the risks and can make an educated decision is very important. Not so much in pediatrics, but some people, I tend to find this more in our older population, but have bunion surgery in order to wear more fashionable shoes or for more of cosmesis purposes than actually just for pain. So hemiepiphysiodesis or epiphysiodesis. Hemiepiphysiodesis, also known as guided growth, is a surgical technique used to gradually improve or ideally correct an angular limb deformity in skeletally immature patients. The degree of deformity that you can get with this will depend on the amount of growth remaining in that target bone. Literature for all of this is limited. It was first described in the 1940s, and there are several ways to do this. Staples and A-plates have commonly been described depending on location or surgeon preference. So this is a level 4 retrospective case series of 24 patients, which was published in 2019. Mean age was 12 years, 35-month follow-up, and the AOFAS scores improved as well as the Hallux valgus angle and intermetatarsal angles also improved. All patients had rapid return to school and sports, and there was no complications or overcorrection. So they concluded that hemiepiphysiodesis, although it does not create as much correction as an osteotomy, it is still beneficial in symptomatic patients who are skeletally immature. This study, published in 2018, aimed to evaluate the safety and efficacy of temporary screw epiphysiodesis of the lateral epiphyseal plate of the first metatarsal. They had 33 patients, 59 total feet. The mean age was 11 years, and these patients were followed both clinically and radiographically, and they concluded this was an effective, safe, and technically easy minimal incision early treatment option to correct juvenile hallux valgus. This study was a study of 12 patients, 22 total feet with juvenile hallux valgus, which were treated with lateral hemiepiphysiodesis, average age of 10, average follow-up 3.5 years. And they also had improvement in the AOFAS score. Intermetatarsal angle decreased by 2 from 13 to 11, and the average MPA or HVA decreased from 26 to 22. Here's some of our cases. Here's one of our cases. This is an 11-year-old female who presented to the office for progressive painful hallux valgus, difficulty finding comfortable shoes. So here was a surgical technique that was used. You can see kind of the order here. So lateral aspect of the physis was threaded out, and then a radio-opaque dye was placed within to ensure that an appropriate amount of the physis was removed. More commonly, we will use minimal incision surgical technique to correct these patients, as we often get more correction. So this is level 3 retrospective review comparing 25 MIS to 30 distal chevron metatarsal osteotomies. And this was done in young females with mild to moderate deformity with a minimum of 1 year follow-up. Radiographic and clinical parameters were not statistically significant. There was no statistical significant difference between the two groups, concluding that the outcome of the two methods was equivocal. Regarding the correction power, there was no significant difference with any of the 4 parameters shown here. There was also no statistical significant difference in the AOFAS score. 22 of the 25 MIS and 20 of the 30 DCMO gave positive answers when asked if they were cosmetically satisfied. However, it is really important to look at the operative time, as the operative time was 23 minutes versus roughly 45 minutes in the DCMO group. And the length of incision was 9 versus 45 millimeters. So significantly shorter in the MIS group, significantly smaller incisions as expected, as well as a pretty significant difference in operative time, which is important when you have a younger patient. We obviously worry about the risk of anesthesia as well as cosmetic appearance. So those are 2 important things to consider. So when you are doing MIS, you want a burr with low speed and high torque. If you use a tourniquet, then the saline cooling of the burr needs to be used. We actually do not use a tourniquet and also use the saline cooling to prevent thermal necrosis or damage to the bone, and patient positioning is key. So here's just like a demographic of the OR setup for a right limb if your surgeon is right-handed. So the surgeon will be at the distal end of the table, and imaging will be on the contralateral side. And then here is the setup for a left limb, again with a right-handed surgeon. The surgeon will, in this instance, be on the left side, and the imaging will be on the contralateral side. I personally like to put the leg in a leg holder, either an arthroscopic leg holder or a trauma leg holder, so that the foot is gently set against the bed and kind of simulates or looks like weight bearing, making imaging more consistent and just decreasing the fiddle factor of having the leg and everything kind of move around a lot. So for osteotomy planning, if you want a neutral osteotomy, you have to angle slightly distolateral, approximately 10 degrees, to compensate for the 2 millimeters of shortening that you will create with the burr. And then similar to normal principles for traditional osteotomies, if you want to lengthen, you will aim towards the 3rd or 4th metatarsal head. Conversely, if you have a relatively long metatarsal and you want to shorten, then you'd aim slightly proximal. But again, remember that you will be shortening 2 millimeters with the burr. So here's our technique on the lateral. Before we even start, I just mark out the bisection of the first metatarsal head on the lateral aspect of the foot. And then on the AP, I mark out my osteotomy as well as the first tarsometatarsal joint, because I know the guide wires and screws are going to be just distal to that tarsometatarsal joint. If I have an open physis, I will mark that out as well, and then know that I have to start my screws distal to the physis. After marking the patient out, we then place our 2 guide wires. We penetrate the far cortex of the metatarsal and then draw the guide pins back within the medullary canal so they're not in the way when creating the osteotomy. A stab incision is made at the neck of the metatarsal where the osteotomy is going to be created. And then with the burr, you go through and through from medial to lateral across, and then use your sweeping technique to create the osteotomy. After the osteotomy is created, we use a hemostat to go within the medullary canal and use the handshake technique to translate the capital fragment or metatarsal head laterally. You can also rotate the metatarsal head by twisting or moving the hallux. So here's fluoroscopy images of the cut being created. There's us putting the hemostat in and sliding it over. Then we drill over the top of the wires, or we advance the wires, drill over the top of the wires, and place the screws. So here's one of our patients, 14-year-old male with a right pediatric hallux valgus deformity. Patient had attempted conservative options with no improvement. mom reported that her son could not even wear sneakers because the irritation in the pain medial aspect of the foot. The hallux valgus angle was 29. The distal metatarsal articular set angle was 29. The intermetatarsal angle was 18. And the metatarsal articular angle was 27. So we performed the MIS surgical correction. The capital fragment was rotated and translated laterally. Care was taken to ensure fixation components avoided the physis. So the hallux valgus, you can see pre-op versus post-op, both images and angles there. So hallux valgus postoperatively was roughly 18, distal metatarsal articular set angle 12, and intermetatarsal angle of 13. So here is a 16-year-old female with left pediatric hallux valgus. Similar instance, mom reported previous conservative treatment under the guidance of another physician. However, she continued to have pain and difficulty finding shoes. Hallux valgus angle was 33, distal metatarsal articular set angle 35, intermetatarsal angle 20, and metatarsal articular angle 23. So here are her postoperative image, a side-by-side comparison. You can see we had pretty good correction with her, pretty significant shift. Postoperatively, hallux valgus angle was 23, distal metatarsal articular angle 21, and intermetatarsal angle of 15. So our post-op protocol for all of our patients' pain management, we just have them alternate Tylenol and ibuprofen, granted, or assuming that they can take those. And then we just give 5 tablets of oxycodone 5 milligrams. We have our patients non-weight bearing until their first postoperative visit while the incisions heal, which is usually 7 to 10 days. Then at that first postoperative visit, patients will be given a cam walker and they're able to protective or full weight bear in the cam walker. And then we'll see them again roughly 6 to 8 weeks later, and we check for bone consolidation. So here's a side-by-side comparison. You can see a side-by-side comparison of the bone consolidation. So starting on the left is the patient's preoperative image. The image directly next to that, you can see along the bottom the different weeks, and you can see in the images how the callus and bone consolidation formed very nicely. And then moving on to Lapidus, or first tarsometatarsal joint fusion, which is definitely necessary in some patients. So here's a classic article on juvenile hallux valgus, which was published in JFAS back in 1999. It was a retrospective review of 23 adolescents between the age of 13 and 20 who underwent a modified Lapidus procedure. Their mean follow-up was 61 months. Posteriors, the patients were placed in a posterior splint for 2 weeks and then a below knee cast for 4 to 5 weeks. So total non-weight bearing period was 6 to 8 weeks. Historically, procedures chosen for pediatric hallux valgus, as we spoke about earlier, include osteotomies of the metatarsal or epiphysiodesis, but these procedures do not address a hypermobile first ray, which may lead to a high rate of recurrence. So like I discussed before, some of those different tests to look for overall ligament laxity is important. And so in the study, 90% had excellent or good results based on the modified Bonney and McNabb score. So 25 excellent, 3 good, and 2 fair. 27 of the 30 had either good or excellent results, which is similar to Clark article, which reported 91% good or excellent results. Preoperatively, 21 of the 23 patients had difficulty wearing dress shoes. However, postoperatively, all 21 were able to wear fashionable footwear without discomfort. So individuals with preoperative limitations on physical activity reported an increased postoperative function, and there were only 3 complications or 2 recurrences. And there was an 8-degree decrease in the intermetatarsal angle related to preoperative evaluation. So here is one of our patients, a 15-year-old with a congruent joint, hallux valgus angle of 35, distal metatarsal articular set angle of 30, and distal valgus rotation. She had increased met cuneiform joint obliquity and an intermetatarsal angle of 16. So a fusion of the first tarsometatarsal joint was performed, as well as placement of a screw between the medial, and intermediate cuneiform. This procedure was approved back in 2019 for children over 12 years old. Immediately, patients can weight bear in a CAM boot, theoretically immediately after, but we tend to not allow our patients to weight bear until their first postoperative visit. So patients can weight bear in a CAM roughly 7 days. And in this patient, there was an adequate reduction in the hallux valgus angle, distal metatarsal articular set angle, and the distal rotation was improved as indicated by the sesamoid position, as well as improvement in your IMA and your cuneiform joint alignment. So lastly, soft tissue joint procedures. Are soft tissue procedures alone enough? The answer is no. If you fail to recognize a deformity such as an abnormal distal metatarsal articular set angle, you will have suboptimal results. So in summary, juvenile hallux valgus can have significant consequences on a patient, especially in pediatric patients, on their psychosocial as well as their physical ability when it affects their ability to wear shoes, as well as can have consequences on growth and development. You always want to start with conservative care, and surgical intervention may be warranted if the deformity progresses and becomes increasingly painful or impacts their activity or ability to wear shoes. Many different options, your epiphysiodesis, osteotomies, whether open or closed, or a lapidus or fusion of the first tarsometatarsal. And you always want to consider all the planes of the deformity when determining which type of procedure you are going to do. So here are my references. And then if anyone has any questions.
So Joslin, that was excellent, everything that you presented. One thing I was just wondering, Mark, if you can kind of take us through the conversation you have with parents about the deformity and kind of when is it appropriate to pursue surgery. Certainly the one thing that we hear from our adult patients is that this is, their painful bunion has been a problem since they were a child, and their pediatrician advised their parents not to do anything about it at the time. And then, of course, later on in life, it's a lot more problematic for somebody to take time off of work, out of college, and then they don't have people at home to help them necessarily, versus maybe having it done when they're younger, and it's a lot easier for the caretakers to help them. So I'd just be kind of curious to hear what your conversation is like when you talk to parents, and trying to answer the questions is, when is it actually appropriate for my child to have the surgery, or should they wait till they be, go to high school or college or whatever? Any ideas or suggestions, that'd be great.
So, it's a great question. It's something that we deal with obviously quite often. And there's a couple, basic indications. So, if somebody's coming in and they're telling us that they have pain, just like, you would with an adult, if there's some sort of disability, if the kid is having trouble participating in activities. One of the common things that we'll see is there are a lot of soccer players that have trouble with cleats or lacrosse or any of the field sports. So for that, we'll try to get them through the season by doing little tricks, such as like cutting the cleats. So I work with the New York Jets, but only when they're winning. So a couple of times a season. And that's something that we always did with them, because a lot of the football players love to wear their cleats 2 sizes too small because they feel like it gives them better agility. So we'll try to get the kid through that season of the sport so that at least they can complete that. Then, we'll have the discussion and kind of explain to them that, it's really only 7 to 10 days off your foot. We'll have immediate weight bearing in a boot or cam walker. They're not really using any other type of assistive device. The one thing that I think is really not talked about enough is really the psychological distress that a lot of kids have. So when I also hear that the kid won't wear like open shoe or sandals to like the pool or the beach, and that clearly is something that somebody in Florida is probably going to see a lot more than somebody in the winter months in New Jersey. But I use that as an indicator because also treating adults, although it's probably about 10 to 15% of my practice, it was bigger at one point in my career. You hear a lot of adults saying that that they've had this like distress over people seeing their feet like their entire lives, and it really has affected them. So I kind of like talk to them about that. And, we find that kids start to get mean about stuff like that around age 6. So the other types of deformities, like either like a syndactyly or a polydactyly, we try to take care of by that age. Obviously the bunion's really not going to become prominent usually until I don't know, around age 8 to 10, I think, is when you're typically going to start seeing it form, and then it may get a little bit worse as sports go on. So, that's basic. That's the basic conversation that we have with them, and we have them talk about it. We talk about whether the parent also has a bunion. Because you're seeing an 80% matrilineal descent as far as that goes as well, or talk about one of the concerns that they always have is recurrence, because that's really what they're hearing from that pediatrician. So you try to explain to them that recurrence is not really what you would hear about in the literature, because it's just that the types of procedures that we're doing nowadays really do address that rotational deformity that potentially is also affecting it, and trying to assess the DMAA and address that as well will also decrease the risk of recurrence. And the other big factor that's often missed is long first metatarsal. So I actually gave this lecture or version of it, my version of it, a little bit earlier this morning at Michigan, and I showed a couple of the MIS procedures in which we also addressed the distal metatarsal articular angle by basically creating a wedge. I'm trying to having a senior moment as far as the article that talks about the. Let's see, I think I have it here. So yeah, there was an article by Warnick that basically explained how to actually angulate the wedge when you're performing the MIS. Well, he was talking more about ankle surgery, but it can be applied to MIS surgery. So using a larger millimeter burr or doing a double cut on the medial side will tilt the head and correct that distal metatarsal articular angle, along with shorten the entire metatarsal, which is what will also lead to recurrence. So trying to explain it in layman's terms to a parent that the rate of recurrence is going to be a lot lower than the pediatrician is telling them is an important factor as well. So did I address the question, or did I just go off on a tangent?
Thank you. One thing I was going to say is that when I talk to my pediatric patients, you're not just talking to the patient, but you're really trying to settle the fears of the parent too, and not do it in a way that gets the child very nervous. But one example I say is, look, your child either has a Disney foot or they don't. So if you go to Disney and you take your child, are they going to be halfway through complaining of how much their foot's bothering them? And if you're hearing that as a parent, that's actually pretty serious, because a lot of times kids, hide their pain when they're having fun because they don't want the pain to get in the way. So when I start hearing parents say, oh yeah, they're always wanting to sit down and take off their shoes, that's a big sign to me that this is probably something that needs to be addressed sooner than later. If it's like, oh, no, they never really complain, or it doesn't hold them back, then for me, it might be a conversation to have later, because I typically don't like to fix things that don't hurt, because there's a chance that after surgery they might have some sort of discomfort. But if they had a lot of discomfort beforehand and they have a little bit afterwards, it's a big improvement. And the other thing is I always kind of try to settle fears by saying, you know what, usually, especially like with pediatric flat foot, it's a bilateral problem. And what it always happens is that the child is not wanting the surgery and the parent is kind of wanting it. But by the time you go to the second foot, it's actually the child that can't wait to have the second foot done, because they never really knew what a normal foot should feel like. So once they actually have a foot that's feeling better, then they're excited to have the other foot feel the same. So those are some things that I picked up on. Andrew, I know you see some peds, and Brad, I think you see a lot of peds. So I'd be interested to get your input on those conversations you have with parents.
I guess I can start. Well, this kind of ties into my question for you guys, actually. The question is, when I see these pediatric bunion deformities, many times it's associated with a flat foot. And sometimes it's a severe flat foot and sometimes it's a mild or moderate flat foot. And I usually try to take advantage of the opportunity of fixing the patient's bunion with a flat foot correction at the same time. And, obviously for severe ones, those are no brainers. You got to do both to get a really good correction and to get the alignment. I think the trick and the hard part comes in deciding when is it mild, moderate, to then add the flat foot situation. If I don't do a flat foot, and there's usually an associated equinus, I will do some kind of equinus release, whether it's a Baumann or something like that, or Strayer. So I guess my question to you guys is, when do you make that decision? What's your algorithm? And my conversation with them is, listen, if they're going to go and have surgery, let's do everything that we have to at one sitting to make it right. Bone takes 8 weeks anyway. Whether you ambulate them a little quicker or not, the kids are going to do better non-weight bearing. They can do better non-weight bearing, I should say. So for me, I push the total correction. So maybe you can talk about that.
Sure. I mean, the only definitive combination of flat foot and bunion that we do is in a neuromuscular child. So, if we're seeing we have a kid that has some sort of neuromuscular issue, has a flat foot and a bunion, and there's pain, dysfunction, dysfunctional lever or just disability, then we're going to automatically do it. Otherwise, in a neurotypical population, we're not running to correct that flat foot. I mean, really flat foot surgery. Surprisingly, we see a ton of flat foot in our office, but we're really operating on a very small percentage of it. I would say it's probably less than 5% of the flat feet that come into the office we're actually saying is any type of indication. And they typically have to have some sort of significant disability. They have to be, a lot of times they don't want to participate in activities or obese, something along those lines. But otherwise, we're not really trying to fix everything at that same time. We're trying to do really what that kid needs, try to leave zero footprint long term in these kids, and as little correction as possible if they're functioning and not having an issue, except for that case with a neuromuscular patient.
Brad,
And just another point, sorry, I was just going to say, just to address that pain point that you brought up earlier, I generally don't ask the kids if they're having pain. Pain is, it's their normal. If they have some sort of congenital deformity, they don't know what it's like to not have that. And so, I rarely ask them, is it painful? Because you're really going to get an answer of no. There's so many tarsal coalitions that come into the office, and they're not telling you it's painful. They're like, oh, I sprained my ankle, and this is like the sixth time I've done it. So, they don't know what normal is. And then, as soon as we fix that coalition and they come in the office and I have them stand that first day, they're like, oh my God, I'm wobbly. That joint never moved like that before. I didn't know. And we had a girl today actually that I fixed it. I fixed her left. It was a CN bar last year. And the seventh day post-op, she came into the office. I took the splint off, and she went to gymnastics practice and then competed 3 weeks later. So she didn't know it was a problem beforehand, but she realized, oh my God, now I can do point and ballet. It's amazing. It's like a tremendous difference. So just to address that pain thing, the pain thing that you were talking about, Adam.
Yeah, usually when I ask that question, it's more to the parents, just observing, if their child is participating in things or not participating. And a lot of times it's very subtle. It's like, oh yeah, they just prefer to do, they prefer to read a book or whatever. And when you say, well, do they run around with their friends or keep up with their friends? That's when you start to kind of tell that there's something there. But you're right. Kids almost never say they have pain. They kind of they don't want it to get in the way. Or a lot of times they know that if they say that they're having pain, it could lead to a surgery. So they're doing everything they can to avoid the pain subject. But it is an interesting thing. And for me, it does factor in, but it's more me listening to the parent or asking the right questions to the parent to identify how much it is actually impacting what they're doing. And I guess my philosophy on the pediatric flat foot is maybe a little bit different, because I see a lot of the adults that come in and they've had this problem and it's become a really big issue for them, and it might have even changed the career that they chose to, the career path they chose to go on. So when you have a curve that's like, like this, this is normal and this is abnormal, the closer you are to the bottom, which is basically birth, the easier it is to get it back to a normal. But when you get into the 30s and 40s and you've been dealing with that really bad flat foot for a long time, now there's knee problems and hip problems, and you can fix the flat foot, but you can't always fix all the associated problems. So I think philosophically, I've kind of been a little bit more aggressive with my flat foot. And I think kind of what Andrew was saying is I try to identify it relatively early on, but Mark, it is important to identify what's a painful flat foot versus not. To your point, not every flat foot is painful, and nor is it holding a child back, and there's no reason to do anything until it really starts to impact. Brad, what are your thoughts?
Yeah, so I have a question for Mark. As far as, at least my background is, wait till they grow up and then you do a Lapidus. That's kind of how I was trained. Then, of course, doing some of my fellowship training, we were doing the hemipiphyseodesis. Yeah, you have to get them at 9 or 10 early in age to have enough growth remaining. I did write an article in JPO about, predicting foot length in children. And so, that's really critical if you're doing that procedure. But my personal concern is these, the MIS type bunions done on kids where, are you seeing recurrences? Is this fixing the deformity? Are we just masking it for a short period of time? And are we excited about a new instrument and not really addressing the true deformity? So that's my question to you, Mark. What do you think about that aspect and kind of the longer term follow-up cases you've seen? And so
good point, and there's plenty of literature in JPO to address, like, just doing the open chevrons. So with the MIS, I mean, we're just doing a smaller incision and doing obviously a lot more translation. But I think long term, that one slide that Dr. Seidel had up where she showed, over time that you get a significant amount of bone regrowth in that entire region. That looks like a stable first met. Do you think otherwise? I mean, I'd love to hear what your opinion is on that.
No, I think, yes, definitely moving the metatarsal head into a more lateral position, balances your tripod, you know what I mean? And also balances the soft tissue envelope around there, extensor, flexor, apparatus, etc. So that is definitely key. I mean, with this particular example, I would say, I'm worried about the medial bump, worried about the angle of the screws, but yes, you have the growth plate there. So I guess, my concern is that, short term, yes, we're balancing the foot, so to speak, and you're lateralizing the head, but long term, isn't the hypermobility just going to come back? Isn't the IM angle going to increase? Isn't the growth plate going to still grow in this abnormal position? And and are we going to see them when they're 40 years old? And like I do, I've seen some adults where they've had childhood bunion surgery and they're still deformed or redeformed or became more hypermobile. You know what I mean? So I just wonder what you've seen, Mark, in that aspect, because I just think, that's my thinking on this kind of on a longer term basis.
So that's a great point. I mean, if you think about, the Hutter-Volkmann principle for something like this, prior to this, if you look at that initial deformity, you're probably having a stress-strain relationship and having that growth plate on the lateral aspect continue growing because it has less tension on it. On the medial aspect, it's kind of cease growing or decreases growing, and you are having a wider IM angle long term. So potentially by fixing that tripod, you're having a balancing of that physis. Most of the time when we're doing this, we're doing this after menarche. So I don't remember exactly which patient this is, but most of the time it's at least 6 months past menarche. So you're really only having maybe like a half degree left. I mean, I believe your article in JPO it quoted that to be around 1 degree per year correction if you're doing it at like 8 or 9 years of age, correct? And I think there was an article by Raymond Liu out of Case Western, he's a pediatric orthopedist that also kind of came up with a formula, and it ended up being that it's not hemiepiphyseal is not very gratifying procedure, and we were doing it at one point and finding that after once a kid hit skeletal maturity, we were having to go back and fix it. So hemiepiphyseal I did believe had a high recurrence rate and a very low correction rate. As far as MIS, I think long term it's going to be okay, but I guess time will tell. So maybe we can do a joint paper together on something like that because we have plenty of patients that we've done it on.
Well, I was going to just make a statement and because we have, obviously some people on this call that have designed MIS stuff and top core and everything. This has been a big debate for a while, and I will tell you personally, I was a big lapidus person. Frontal plane derotation really opened up kind of a whole new understanding. And one of the things that I've had to kind of grapple with is what we're doing actually when we do these MIS cases. But the thing that's helped me is to think of these sesamoid bones like the reins of a horse. If you have the reins off to the side, no matter what you do to stop your horse, the horse's neck is always going to cock sideways and you're going to turn sideways. So if you correct a bunion through chevron and you're just translating but not derotating, you're not correcting the reins of the horse, and the chance of recurrence is much higher because the pulley system on the big toe is always going to be off to one side. Therefore, the toe is going to track that way. So the thing that helped me maybe embrace MIS a little bit more is the fact that the big toe itself doesn't really care what's happening behind it. It just cares that its soft tissue is balanced. And that's what, when you center the sesamoid apparatus, you're getting more equal pull, kind of like putting the rein on either side of the neck and then trying to stop your horse. That's ultimately what you're doing, whether you do a lapidus or an MIS case. And I think the long-term studies will show us whether or not it's correct regardless of where you do it. We just know with Cora, the further you are away from the center of rotation, the more you have to translate. But I think the key element in both of these techniques is the restoration of the soft tissues and, more importantly, the cristae in the sesamoid. So that's just a personal observation. I'm kind of curious. Mark, I think you've been doing this for a while and probably were addressing peds before this whole frontal plane came about. That's really been in the last 6 or 7 years. How has the treatment of pediatric hallux valgus changed with the new understanding of the frontal plane importance? And Brad, I'd like to hear your opinion on that as well.
I mean, as you said, it's an important factor. And, I at one point, I was doing more lapidi procedures, as I like to say. But I have since moved away from that. And I find that, the correction with MIS has been great, especially with, doing like a handshake and rotating while you're actually shifting the head over. So, I guess time will tell, just like everything else.
Andrew or Brad?
Well, I do have to say, I think for me, before this kind of modern technique, what I was doing, I hate chevrons. I stopped using them as soon as I got into my 5th year practice, and I would switch over to Revierdens or those types of procedures. I felt just I could get better correction. So for a pediatric who had a little bit of a larger IM and I didn't want to get it in the head, I would do an opening wedge, cotton type thing, direct it a little more medially, get the correction behind the joint, and then get the rest of the correction through the head. I usually find that some of these kids have adaptive changes on their PASA, so you definitely have to fix that. I think that's the cool thing about this particular type of procedures. If you're just looking at isolated first ray problems, you can actually rotate it and move it in a way to correct PASA, and you can plantar flex it if you want to, which I usually do. And you can you can rotate it for the sesamoids. And so I think as long as your goal is to try to, correct the biomechanics around that first ray and keep all those structures straight, I think we should be doing more of the cuneiform procedures to help with these. But again, you're looking at more time, more healing. It's not quite as studied, but as much associated with a med head. osteotomy. But I mean, I think this is a good option. I still feel strongly about attending to the flat foot with these, and I think you're going to have better long-term correction.
Just from a debate, what's more effective if you have a collapsing medial column or hypermobile first ray, to do an MIS and a cotton with an MIS, or is it better to do some sort of plantar flexury lapidus? Both are trying to achieve the same things, but obviously differently. So is there any advantage of one over the other? Has there been any thought to that in terms of maybe restoring the pronaos longus? Is one more effective than the other? Or is that even part of our thought process at this point?
For me, I'm sorry, Brad, why don't you go? I've been talking too much. Brad, you start.
No, just looking at the x-rays, how it looks like the IM angle or the sesamoid is drifting further from the second metatarsal. I don't know. It's probably just positional, or maybe I'm looking into things too much. But I think the problem is the whole, being a bunion so big, so young, it's some sort of instability of the cuneiforms, Liz Frank, midfoot. That's my feeling. I really think that you can move the first metatarsal where you want, but it's still going to, have issues longer term because, these feet have more hypermobility through, I think, more of the midfoot. And I think we're finding that out more and more because we're doing more and more of these bunion procedures, and we're seeing, this gentle drifting or loosening of our lapidus or MRIS or whatever we're doing. So that's my take on it. I don't think we figured it out.
No, actually, just to your comment, I've seen both MIS and lapidus drift over time. So we're obviously missing something. I don't think we've quite figured it out. What's the best way to hug that first metatarsal in towards the second metatarsal? There's different systems that do things differently, but I don't know that any one of them can say that they're 100% effective all the time. And this goes back to what causes HAV. It's 100% multifactorial. Some of it's hereditary, some of it's ligamentous laxity. We can say the older they get, the more likely it was caused by activities and shoes, but it is so multifactorial and it's hard to pin down in each person.
Exactly my point. That's why you have to fix the rest of the foot in order for this to work. Have you ever tried to fix a flat foot and you forget the medial column, or you didn't do a good enough job plantar flexing that first ray, and then it drifts into valgus again, even though you did everything else correctly, everything else perfectly? So these are going to potentially have problems if you don't fix the entirety of the foot, especially in a young pediatric patient. You have to get it right, and you have to be aggressive with them. I just think that now what will happen is it may drift a little bit over time, but the patients are comfortable because you still made them better than before. So it's not wrong. It's just, if you're talking about what's making these things worse or drift, I think if you don't get everything right, it's gonna still have some trouble.
Mark, I do have a question. A while ago, we saw some of these temporary fixations, where you do a tightrope procedure, and that for me failed pretty miserably. I had a couple second metatarsal fractures, and I was like, forget that. But now you have some newer technology that is maybe more promising in terms of holding the reduction. And Brad, I know you've used some of the newer products that do that. Is there any thought process to maybe temporizing this at a younger age, and then at a later date coming back and maybe doing a more definitive whatever we decide to do, whether it's a MIS or a lapidus at that point? I mean, I guess it kind of goes back to that debate of, do you do stay pegs in a younger child and a flat foot in an adult? And we've seen trends go to and from, more of those MIS sort of flat foot reconstructions, even though in some patients they were amazing. They worked really, really well. But I wonder if there's any sort of debate or discussion that can be had about some of these newer flexible systems that don't really burn bridges in terms of osteotomies. You're not zigzagging a metatarsal that is going to need, if it ever does recur. I mean, you can't just go and do a lapidus on that x-ray to the far right if it recurs, because you can only get the second metatarsal head or first and second metatarsal head so close together. But just curious to hear everybody's opinions on, is there a place for some of these flexible systems with no bone fusion or osteotomy in the pediatric realm?
I really don't have experience with them, but just doing something that would temporarily fix something so you can go back at a later date is kind of against one of the tenets in any of the pediatric ortho surgery, which is not to do something that they call birthday surgery, which is like doing it like once a year, every year. We do try to kind of get something like that. If we're going to fix this, we're going to try to do that osteotomy, but do joint sparing. I mean, we at all times try to eliminate any type of arthrodesis because that definitely has long-term effects. Um, that's that. I mean, some of the interesting things. I mean, we could talk about pediatric flat foot all night, but one thing that you mentioned the cotton. There was a lecture that I saw given by Dr. Vincent Mosca from Seattle about what he calls the reverse cotton. It was about 5 years ago, and it completely changed the way that we do flat foot surgery. We don't put the bone graft and perform a cotton anymore. We take a wedge out of the plantar aspect and put like a staple.
Yeah,
And
I've
that's
done that.
when you actually when you actually do a cotton and put a wedge on the dorsal surface because of the anatomic alignment of the ligamentous structures connecting the medial cuneiform to the rest of the midfoot, it actually causes a forefoot valgus. And doing a plantar wedge resection of the cuneiform will actually bring the foot, it will adduct the forefoot along with plantar flexing it. It's on Posna Academy if anybody wants to watch it. It's about they clipped out 6 minutes of it. It's an excellent lecture.
That's actually fascinating. I hadn't heard that, but that's a fascinating way to do it.
Yeah, that's a good article too that they wrote about the closing cotton, and I've done it, and it's worked out fantastically. And especially for a very long first ray, that's probably your procedure of choice. Sometimes these first ray deformities, they already are long to begin with. So if you put a cotton wedge, you're going to just exacerbate that problem. So yeah, good thought.
Well, does anybody have any other questions, or Brad, do you have any other comments?
No, I thought it was great. I am using the flexible reduction, device for kind of the juvenile bunion because I feel like it's, as you mentioned, doesn't burn any bridges. Long term, how's that going to work? I mean, we don't know, but I definitely think is some merit to at least look into. So I'm looking into it.
Real quick on that, are you able to address the frontal plane with that? Is there a part of that technique that rolls the metatarsal at all? I was just having.
Yeah. So reduction allows some rolling of the metatarsal, but also the placement of the device can help you roll it some more. Yeah, it's pretty impressive how much it can correct through just the kind of tightrope type device. So.
Yeah, I think the one thing that we all want to strive for, there's something called LMT, which is actually it was originally LNT, which is leave no trace. So you go to the top of a beautiful hike and you look around and you're just enjoying the scenery. And then if you camp up there and leave all your trash behind, the next person that goes up there just doesn't have that same experience you had. So for me with pediatrics, I'm always trying to figure out how to leave a minimal trace. So that way, if the child needs something as an adult, you're leaving as little scar tissue behind. And that's the only thing that concerns me about the intramedullary devices with, some of the MIS cases is that you are leaving an indwelling implant in there that obviously will have to come out and that can destroy the bone a little bit, taking it out. I guess it's no more different than if you had a lapidus plate, but at least it's a little bit more external. We don't know long-term what that's going to be, but you are having a lot of scarification of the bone. And yes, it is joint preserving, but what does it take to reverse it or address it if it does recur? And that's my only concern that I'm still hanging on to with my MIS is long-term effects and reversals. I feel like I can revise a Lapidus easier than I'd be able to revise a recurrent, really, really large push on an IM angle with an MIS case. But I think this is a debate that we'll be able to come back in about 10 years and have a really, really great look back on literature to see how this all plays out. But none of us really have that answer yet.
Not for bunions. I mean, we have moved to biointegrative screws for transitional ankle fractures. Along the time of COVID, whenever we have like a Tillot triplane fracture, we typically will take those screws out at about like a 12 to 18-month period because of the stress shielding, the proximity to the joint, etc. And again, trying to leave zero footprint. So we had a whole bunch of kids that once the ORs got shut down, that kind of disappeared and didn't come back until about 2-year period to have these screws removed, and a lot of them started breaking because the reverse cuts on these partial thread screws were terrible, and these kids grew such like exuberant bone that it just wasn't cutting through. So we would lose half of these screws in the bone. And so we kind of moved over to the biointegrative screws, and the results have been fantastic because we haven't had to go back for a second surgery with these kids, and there's been no burst effect as previously seen with any type of absorbable screw. So I see that that's probably something that will be forthcoming when you can finally like see these screws under X-ray, know how far your head is. And where the whole screw was kind of sitting in your MIS cases. So I think that that's something that's probably going to answer the question that you just brought up.
Well, Mark and Joslin, this has been an amazing evening. We really appreciate you coming out. And this is kind of what the roundtable is about. It's kind of, we listen to lectures and we get to kind of bounce ideas off each other. And none of us really have answers or all the answers. Everybody's, I think we're all learning from each other. So thanks for being part of the roundtable. And we'd love to have you back
and
maybe get deeper into some of these other pediatric issues because there's so much to learn there. And, the one thing I can say is that just like all the other things that we do, I mean, technology, as it advances, it is making us better surgeons, and hopefully it leads to better outcomes. So I think we should all be, at least I try to strive with my fellowship to teach my fellows that never be happy with the current version of yourself. You always have to strive to improve, and that's what's in the best interest of the patient. So we'll all continue to evolve our craft and hopefully work towards even better outcomes in the long run for our patients. But thank you guys very much. And
thank you for having us. Your mission is fantastic. The goal for everyone to just learn and, have a lively debate, I think is great. It's something that we were doing in northern New Jersey with Dr. Subik and Dr. Napoli. And, it's something that if it's okay, I'd like to bring them over as well.
Well, we do this monthly, and the more people and the more eyeballs we can get on the screen, the better for all of us. So please help us spread the word about the series. Speaking of, we do have our next series coming up, and I just wanted to give a plug for that. And I just have to navigate really quick. So let me grab the calendar. It is Dr. Windrome and Dr. Nishu Vora, and it is coming in March. And let me just pull this open. It's basically, they're actually going to talk about S-core implant technology, which is basically the ability to address OCD lesions of the talus and the first MPJ. And I think they do have some things for lesser MPJs. So I think that will be a really interesting talk as we kind of continue to try to explore cartilage repair. It's something that is very challenging, but I'm really looking forward to that talk, and I hope to see everybody in 1 month. It's the 23rd of March. So we'll all be looking for a nice springtime and hopefully not too much more snow for the Northerners. Well, I hope everybody has a great evening. Thanks for joining us tonight.
Thank you. And we like snow.
Excellent.
Thanks, Mark.
All right. Thank you, guys. You too. Take care.
Bye.